February 21st, 2025 SCDC meeting minutes. So hopefully everybody's had a chance to review the minutes. I will just admit, as I was reading the minutes, I got a little bit confused with regards to the approval of the minutes. We had tabled that motion at the beginning of the meeting, but if you look at page 5, we got back to the meeting minutes towards the end of the meeting. So I just wanted to have that point of clarification, but does anybody have any further comments regarding the minutes?
This is Stephen. I move approval.
Second?
We have a motion and a second. All know in favor, say aye.
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 Any opposed? Motion carries. So I want to get it back to, I guess there's another agenda item number 3, which is the approval of the December 2024 SCDC Executive Committee meeting minutes. And this item carried over from the last meeting from the 21st. And there was a question regarding the voting on executive session meeting minutes. So I, as chair, had asked staff to follow up with council, and we confirmed that the SCDC must approve executive session meeting minutes in public session, and that FOIA actually prohibits voting in executive session. So that being said, I'm requesting a motion to approve the December 2024 SCDC executive session meeting minutes. Does anybody have any
So
questions?
moved. Oh, sorry.
Any questions on that particular statement? I believe we have a motion to approve. Do we have a second?
Second.
Motion made and seconded.
No.
What's that? No. Okay. We do have people that would probably like to abstain from voting. So
Stay.
Karen Peterson, Bill Overly, anybody else want to abstain? Ashley Tucker.
Stephen as well,
Stephen?
since I wasn't there, so.
Paul Baumbeck.
Yvonne Gordon, I was not there at the time.
Thank you.
Get Paul Baumbeck.
I'm not here to provide legal advice, but you don't have to be present at a meeting to approve the minutes of that meeting, in case anyone's wondering. But I was not present and I will be voting.
Thank you.
Well, I wasn't on I wasn't on the board at that point, so is it still, I wasn't part of the committee, so does that not matter?
Yeah,
This is-
that was my
This is
question
Yvonne
as well.
Gordon, that's my question, I'm
It's
Yvonne
not that we
Gordon,
weren't
that's
there,
my
we just weren't on the committee.
committee. So the question is, should we even vote?
I think the Lieutenant Governor has expressed that she wasn't, I believe, at that meeting as well, and she's feeling comfortable to vote for it. She says she's not a lawyer, but plays one on TV.
Okay,
I'm
But-
certain that our council will help us rescind or work through any mistakes we made, but I'm in favor of moving this issue in this meeting since it's already been carried over from another meeting.
Sure, and I second Lieutenant Governor Gay's opinion, and to the extent anyone's uncomfortable, of course, the only question is whether a majority of the votes cast are in favor. So I think the abstentions wouldn't actually harm the vote here, to the extent anyone's uncomfortable.
thank you.
Thank you, Ms.
So I
Miller.
will vote, I just didn't know whether I could or not, so thank you for that opinion, and so I am comfortable voting.
Karen Peterson would like to comment.
And this has nothing to do with voting, but the executive session minutes, don't really contain anything confidential. And so, but I imagine they could at some point. Is there any way they could be sent to us separately so that if we want to share the documents from the upcoming meeting, it wouldn't include the executive committee minutes?
How we handled that in the past.
So the materials for the meeting are posted the same time they are distributed to the committee members with the exemption of a confidential documents, which would be the executive session minutes. So the moment I send them out to you guys, the public documents are posted to our SCBC webpage as well as the public meeting calendar where anybody from the public can access them.
Okay, so the executive committee minutes aren't public at that point?
No, those are confidential.
Okay, so what I'm suggesting is, can they be separated out? So that if I want to forward all this information to other interested parties, I wouldn't have that confidential document tucked in the middle of it.
Yes, we can do that going forward.
Okay.
We can send a second email to committee members with any confidential.
Okay, great, thank you. Thank you, Mr. Chairman.
All right, so I think we're still stuck on this motion. I think we should just do a revote of the people since we've had a little bit of a discussion. I think, Ashley, you have a question?
I was just gonna change my vote from abstaining to in favor.
All right, so if we could just have another motion to approve the executive session meeting minutes from the December 2024 meeting. Can I get a motion?
So
for that?
moved.
Can I get a second?
Second.
Got a motion and a second. All those in favor, please signify by saying, raising their hand or saying aye.
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 We're getting these votes. Any noes? Abstentions.
Abstain.
Abstain.
So I got Bill Oberly, Karen Peterson, and who, there was one other I heard.
Paul Bombach.
Hold on. Okay, thank you so much.
Mr. Chairman, before we move on in the agenda, I got an email from somebody who does these meetings virtually, who said they can't hear us when we're talking. They can hear when WTW folks talk but they can't hear SCBC members, nor can they see us. They said at one point, if there was a full screen of the room and they could see who was here, but then it shrank down to a little black box, which they can't enlarge. So I don't know if there's anything we can do about the audio and visual to help people hear what's being said and who's. Yeah, that shows up as a little tiny black box on their screen.
Mr. Maxwell, can I offer a suggestion?
Lieutenant Governor, you may.
Thank you. Senator, I experienced a little bit of adjustment to Teams in the first meeting, but for anyone watching on Teams, I would suggest that they choose the large gallery mode where they can see shared documents, but also they can see the room you are in. They can also pin the room that you are in. And I'm sure that our staff can work to provide best practices for viewing this online and potentially share those in the public meeting so people have that. But I've had zero trouble seeing or hearing as long as I use the technology features that are available to me that maximize that opportunity.
Okay, thank you. And then maybe you could send some advice that I could share with the people who can't see us or hear us.
Can we include this in the SCBC fun facts, like the next go around?
They get the facts document?
Yes.
Yes, we can do that.
Okay, thank you.
And then additionally, points that were made by the public at the last meeting in the chat was if those in the conference room can identify themselves before speaking, that would be helpful. Those of us who are remote, Teams will highlight us and therefore you can see who's speaking if you're watching remotely. But those in the conference room, it's just someone in the room is speaking and it'd be helpful if the person could self-identify. Thank you.
Great. All right, I think we can move on to agenda item number 4, which is the director's report, and I'll turn it over to Faith.
Thank you, Director Maxwell. Good afternoon, everyone. Faith Renz, Director of Statewide Benefits and Insurance Coverage. I do not have any updates to provide to the committee today. However, I do want to call out, this is a standing agenda item that you will see on each agenda. And it's my opportunity to just provide you with updates on topics that have recently come before the committee or other significant work of the statewide benefits office that pertains to the work of the committee, I do expect to have several updates at the meeting on the 21st.
Okay, thank you so much. Any committee members have any questions regarding that item? Great. Moving on to agenda item number 5. This is entitled FY26 Planning Considerations, and there are 3 items underneath this. A, IMED Vision Plan Enhancements. B, Securian Accident and Critical Illness Insurance Enhancements. And C, Updated Rate Scenarios. I believe Leanne Hinkle from the Statewide Benefits Office is going to handle A and B, so I'll turn it over to Leanne. Thank you.
Thank you. Good afternoon, everyone. My name is Leanne Hinkle, and I'm the Deputy Director for the Statewide Benefits Office. I will be presenting to you some proposed plan changes for discussion and consideration for the July 1, 2025 plan year. Next slide, please. Today's discussion will focus on 2 proposed plan changes. The first change is for the state's vision plans through IMED, which are available to state employees, non-Medicare and Medicare pensioners, and employees retirees of non-state groups. There are 2 IMED vision plans, a low plan which offers lower monthly premiums and higher out-of-pocket costs at the time of service, and the high plan which offers higher monthly premiums and lower out-of-pocket costs at the time of service. The proposed change to the IMED vision plans are specific to coverage for progressive lenses and anti-reflective coating. We will look at the details of the changes in a few slides. The second change is for the state's accident and critical illness, or A and CI insurance, through Securian. The accident and critical illness plan is available to state employees and UD employees. The proposed change to the accident and critical illness plan is specific to the health and wellness benefit. Next slide, please. We will first discuss the proposed change to the IMED vision plans. As background, fiscal year 2025 is the 4th year, or the first optional 1-year renewal period for the contract. As fiscal year 2026 is the 5th and final year of the contract, SBO engaged in discussions with IMED in January, at which time IMED confirmed that there are no rate changes and proposed 2 plan enhancements for the SEDC's consideration. Okay, next slide, please. Sorry. IMED's proposed plan design changes are illustrated on this slide in red. Let's first look at the proposed changes to the low plan at the top of the slide. Under the low plan in place today, the member in-network out-of-pocket costs for coverage for progressive lenses for premium tier 4 is an $85 copay plus 80% of the charge of the lens less a $120 allowance. The proposed change would result in a member cost of $235. Similarly, under the low plan in place today, the member in-network out-of-pocket costs for coverage for anti-reflective coating is 80% of the charge. The proposed change would result in a member cost of $100. The current average member out-of-pocket cost for the low plan is $299 for tier 4 premium progressive lenses and $135 for tier 3 anti-reflective coating. Now let's look at the proposed changes to the high plan at the bottom of the slide. Under the high plan in place today, the member in-network out-of-pocket costs for coverage for progressive lenses for premium tier 4 is a $75 copay plus 80% of the charge of the lens, less a $120 allowance. The proposed change would result in a member cost of $225. Similarly, under the high plan in place today, the member in-network out-of-pocket costs for coverage for anti-reflective coating is 80% of the charge. The proposed change would result in a member cost of $100. The current average member out-of-pocket cost for the high plan is $299 for the Tier 4 progressive Tier 4 premium progressive lenses, and $137 for the Tier 3 AR coating, anti-reflective coating. Next slide, please. This slide looks at the impact of these two plan changes for members that are enrolled in the high and low vision plans who utilize either of these two benefit programs for fiscal year 2024. The top half of the slide looks specifically at the active employee. For employees who had a claim during 2024 in the low plan for a premium Tier 4 progressive lens, 93.16% of those members paid more out of pocket than the proposed plan change of $235. Similarly, employees who had a claim in the low plan for anti-reflective coating, 97.12% of members paid more out of pocket than the proposed plan change of $100. The high plan percentages are 94.9% and 96.45% respectively. The bottom half of this slide looks at the pension group. For pensioners who had a claim last year in the low plan for premium Tier 4 progressive lenses, 88.46% of members paid more out of pocket than the proposed plan change of $235. Similarly, pensioners who had a claim in the low plan for anti-reflective coating, 97.1% paid more out of pocket than the proposed plan change of $100. The high plan percentages are 89.14% and 97.45% respectively. Next slide. So SBO's recommendation is to change the coverage for progressive lenses and anti-reflective coating as noted on slide 10 for both the IMED high and low plan options effective July 1st, 2025. The SCBC will be asked to vote on this benefit change at the March 21st meeting. Are there any questions from committee members before we move to the next proposed change? Yes.
Bill Overly like to make a comment.
Well, a question, if I might. On a net basis, it would appear that the consumer comes out better under the proposal.
Correct.
Okay.
And those are the percentages I provided on slide 5. Yes.
If I may, in the, like 5 to 12% of people who pay more, are we just talking like a $10 or $20 difference, or are there some outliers that are, doubles the cost for them? What's the curve look like?
Yes. So I actually don't have the specific details of the amount that those members would have paid that are faring worse under, or would fare worse under the proposed plan change. I just have the average out of pocket across the entire population for members that had this benefit. But I can certainly pull that for the next meeting if that's something you would like to see.
Yes, please.
If you could, Brian Maxwell's Director of Office Management. Just for clarification, it would be helpful to know what the minimum amount that those people had to pay, going up against now these other thresholds as to what they would have to pay going forward, like the minimum. So that'll be the worst case scenario. Obviously, not everybody's paying the minimal. There may be some range, but if we could have like a range of what those people that are having to pay more, that would be helpful to the committee.
If no other questions, we can go to the next slide. The second proposed change is for the accident and critical illness insurance through Securian. The SCBC voted in December 2024 for SBO to begin negotiations with Securian for the group accident and critical illness insurance plan for an initial 3-year term effective July 1, 2025 through June 30th, 2028, with 2 optional 1-year extensions. A kickoff call for this implementation occurred in January, at which time Securian offered an enhancement to the health and wellness benefit. Next slide, please. The health and wellness benefit exists today under the accident and critical illness coverages. This benefit consists of a $50 claims payment for an employee, spouse, and one dependent as applicable based on enrollment in the plan per plan year for various screenings, including annual physical exams, mammographies, colonoscopies, etc. Securian has offered an enhancement effective July 1, 2025, whereas this $50 claims payment would be for the employee, spouse, and each dependent child covered under the accident and critical illness coverages. Securian is offering this benefit change, which is more in line with how the market now pays for these benefits. While any enhancement of benefits will result in a higher loss ratio, Securian estimates that the impact would be negligible or less than 1%, and confirmed that this benefit change would not impact the rates for the term of this contract, which is July 1, 2025 through June 30th, 2030 with all extensions. Members filing health and wellness claims for the accident and critical illness insurance coverages log on to Securian's website, complete a claims form indicating who the claim is for and how the employee wishes to be paid and the date of that screening. Next slide, please. For fiscal year 2024, Securian paid a total of 487 health and wellness claims, which averaged $90 per contract holder. Total plan enrollment was 3,832 employees enrolled in the accident plan and 3,758 employees enrolled in the critical illness plan. And this was across both the state and UD populations. For the first 6 months of fiscal year 2025, Securian paid a total of 230 health and wellness claims, which averaged $89 per contract holder. Total plan enrollment is 4,504 employees enrolled in the accident plan and 4,414 employees enrolled in the critical illness plan, again, across both state and UD employees. Both SBO and Securian do communicate the health and wellness benefit to employees throughout the plan year. Communications include pre-enrollment emails in April, open enrollment postcards in April, and benefit bulletin articles throughout the year, which are sent to all eligible employees. In addition, post-open enrollment emails in July and postcards are sent to employees enrolled in the plan. Next slide. Therefore, SBO's recommendation is to change the coverage for the health and wellness benefit for accident and critical illness insurance plans effective July 1, 2025. The SCBC will be asked to vote on this benefit change at the March 21st meeting. Are there any questions from the subcommittee on this benefit?
Mr. Chairman?
Karen Peterson?
Yeah, I'm not sure I understand this benefit. I thought I did, and now I don't.
Okay.
So, for example, I don't understand well, first of all, what does it cover? I mean, accidents and what else?
Yes, so there, under Securian, there's two coverages you can enroll in: the accident coverage, right, or the critical illness coverage. So you can, if you're enrolled in either of those two policies, there is a number of situations or claims that you can incur through your health plan that then become eligible for reimbursement under these. So accident could be anything from a broken arm to, loss of a limb kind of thing. And the critical illness coverages are things like cancer or other types of, illnesses.
Okay.
I can get you, we have lots of information on our website. I can get you more specific information on the coverage, but like under the policy.
Yeah, I'm just interested in, for example, fiscal year 24, 487 total paid claims, $90 average paid claims. What does that mean?
Okay, so these claims utilization is specific to the health and wellness benefit, which is a $50 benefit if the person enrolled in the accident or critical illness coverage went and got a physical exam, let's say, right? Then they can apply for a $50 health and wellness claim through the ACNI benefit. So this is not all the claims in the ACNI benefit. It's just specific to the health and wellness claims that were paid out.
Okay,
And the average is, again, because I as an employee can be enrolled in the plan and I can cover a spouse and multiple dependent children. So the $90 isn't the average of the account holder, right? So I can, if myself and my spouse and my dependent all had annual physical exams, I could get a payment for each of those three. So my payment would be $150.
okay, so if you had the state health insurance plan, whichever one you selected, and you all went for physicals,
Yes.
okay, and you had a copay, this would pay that, I mean, this would cover that? Or-
So in that example, I would have to pay the copay at the time of my visit, right? $25 for a PCP copay. And then I would go onto the Securian website and file a claim
Okay,
to get the $50 health and wellness benefit because I got the physical exam.
okay, and what else might that cover, or is that it?
So there is a whole list, annual physical exams, biopsies for cancer, breast MRIs. I have a whole list I can send, but it's basically anything under health and wellness screenings.
Okay, so this would then just, let's say, reimburse the employee for what they paid out of pocket for those services, is that?
That's the idea, yes, but this is a $50 payment and most of the co-pays under our health plan are something less.
Okay, thank you.
Steve, I think you have your hand up, you had a question.
Yeah, I just wanted to add the intent of these incentives, they're kind of called incentive programs, where you get something for actually going to your primary care visit because it will enhance, long-term health. So, a lot of insurers, not only this type of insurance, but even some private insurers now will give you an incentive if you maintain your primary care visits year after year after year. So the idea of this is, yeah, it is also to help with a copay, but it's really to incentivize you to use your primary care doctor on an annual basis.
I think Bill Overly has his hand up.
Yeah, no, Steve took the words right out of my mouth. I sat on the PRC, and I wanted, again, for you to confirm that the enhancements will not result in any increase in the premium.
That's correct, and SecuriNet's confirmed that for the entire 5-year contract.
Any other questions from committee members regarding these particular two pieces of business that will come before us at the March 21st meeting? Seeing none, thank you, Leanne, for that detail. So we're going to move on to 5C now, and I believe we have Brian here from Willis Towers Watson to kind of run us through some updated rate scenarios.
Thank you, Director Maxwell. I'm just going to share my screen real quick. Okay. So recall when we met last, we talked about a few different approaches to setting rates for FY26 and beyond. And we had actually sort of had those scenarios presented in duplicate, one with and one without, one set with and one set without the University of Delaware. Now that the University of Delaware has decided to leave the GHIP effective July 1st, we now only have the one set. We had scenarios ultimately utilizing what we're calling a non-smoothed approach, which means that we set each year's rates, FY26, 27, 28, 29, out into the future, based on its own specific financial needs relative to desired surpluses after reserves. Then we have two smoothing scenarios, which we'll go through a little bit later in the deck. One where we take the requirements of FY26, 27, 28, combine them and produce a single rate action for each of the 3 years equally in order to result in a projected $0 deficit after reserves by the end of FY28. And then an alternative method, which looks at FY26 singularly in a vacuum and then uses that same type of smoothed approach for FY27 through FY29. So under the non-smoothed approach, because of the the large rate action and then the positive experience that the GHIP has experienced so far during FY25. FY26's required rate action in a vacuum would be 0%. Therefore, FY26 rates would equal FY25 rates. But then that would result in higher expected individual rate actions for FY27 through FY29, ultimately ranging between, call it 7% and 11%. One thing I want to point out too, relative to this, is that last year we set we modified the underlying trend assumption that was used in projecting costs out into the future. If you recall, or at least those that were on the committee previously recall, that we had a 6% trend assumption on the medical side, non-Medicare, 3% on the Medicare side, and then 8% on the prescription drug side, both non-Medicare and Medicare eligible. We increased that assumption quite a bit, from 6% to 8% on the medical non-Medicare side, 3% to 5% on the Medicare side, 8% to something much higher on the prescription drug side, pre-65, and then also much higher on the EGWP side, just not quite as impactful as on the non-Medicare side, predominantly due to the impact on the drug costs due to the GLP-1 drugs. If you recall, in fact, if I jump, just to sort of level set us, if I jump all the way to the appendix, this was the trend assumption that we set on the prescription drug side, essentially dominated by the GLP-1 row. You can see we had an assumed 34% trend assumption going into FY26, 31, 15, 10. So that was dominating the drug trends. And I think it's still appropriate to use this trend assumption for the prescription drug side, because the GLP-1 utilization has come in just about right where we thought it was. On the medical side, and give me 1 second, Stephen, there are some indications that medical trends are starting to come down. They've jumped up quite a bit over the last few years, and it seems like it's sort of reached the backside of the peak. These long-term projections that we're putting together, flip all the way back up to where we were, are assuming that same 8% going into FY26, 27, 28, 29, that same 5% on the Medicare side, again, into 26, 27, 28, and 29. So to the extent that we don't approve a different trend assumption, is particularly in the smoothing scenarios, and actual experience comes in better than those, call it conservative trends, ultimately future rate actions will likely be lower. So something when we get around to looking at the trend assumption again and then approving it during the summer before the budget rate setting process, we may want to think about a trend model that goes out a few years and maybe isn't exactly the same number for each of the years, and it's a little more dynamic by year. So I just want to caveat that this model is using what is likely to be a conservative trend model. Stephen, what's your question? I think you're on mute.
Sorry about that. You've heard this before from me. As particularly the GLPs and utilization goes up on the GLPs, your rebates increase proportionately on those. But so the question, and you've heard this from me before, has the percentage of rebate increased on the GLPs as well as the total amount? Meaning, if you were getting a rebate, and I know you can't answer this per the drug, right? I know the rules, the CMS rules. You can't tell me what the rebate is on Ozempic, but you potentially can tell me what the rebate is on the class, if I remember the CMS rules. So the question I have is, if you were getting an average of a 30% rebate, theoretically, has it increased to 40%? Has it, I'm just wondering, because obviously we're all concerned about the increase and and the trend in the utilization and the price of these drugs. But offsetting that, and I know we don't look at it that way. I know we kind of separate out the revenue, the rebate as revenue and the cost of the drug as an expense. I'm just wondering though, if you looked at them combined, does it tell us a different story?
Yeah, it's been a while since we looked at the tracking or trending of rebates as a percent of claims. We certainly do that periodically. I do believe the last time we looked at it, the overall average across all rebates, all classes has gone up. Whether that's due to the increased GLP-1 spend and rebates from those drugs, or whether that's due to enhancements from the market checks that have been done historically, I guess the answer is both. But yes, to your point, rebates as a percent of claims in total have certainly gone up over time, and is reflected in the model. There are other things that counterbalance that, things like biosimilars for Humira and insulin and things like that have caused rebates to come down, on the flip side, but that's all taken into account in the modeling.
Thank you, Brian.
Sure. So let's call that approach 1 to setting rates. And again, specific to FY26, that would mean a 0% rate action for FY26. This table summarizes what the gross rates and employee contributions are, which would ultimately be in that scenario the same for FY25 and FY26, with employees generally paying a low of $42 per month for first state basic single coverage, all the way up to a high of $412 a month for family coverage under the comprehensive PPO. But again, no increase over current FY25 rates. In the next scenario, where we smooth the rate actions between FY26, 27, and 28, in order to, you can see, produce this $0 projected deficit after reserves by the end of FY28, that would mean a flat 4.2% increase for each year of FY26, 27, and 28. And if you recall, in the earlier scenarios, the 0% would be replaced by much higher percentages. And in this scenario, that 4.2% increase would result in these rates, which would mean that employee contributions would increase over FY25 monthly, in a range of $2 per month. Again, that same single person employee only coverage in first state basic, to $17 per month. And I actually think it might be the HMO, but it's possibly the comprehensive PPO, but a relatively modest increase in monthly contribution rates for employees under that scenario. And then the third scenario, which is sort of a comment.
Brian, it's Brian
Yeah.
Maxwell here. I just want to if you just do a point of clarity, just saying that this is as the plan stands in fiscal year 25. It doesn't assume any enhancements to the plan or any plan design changes. Is that a correct statement?
That's correct. It would not reflect any plan design changes, and would only reflect any kind of legislative related changes that have already been adopted and approved. So it doesn't anticipate, it doesn't anticipate any future plan changes, and doesn't anticipate any pending legislation. And even though it's compounded, ultimately, if we're seeing, roughly a range of $2 to $17 per month on employee contributions, it would be about the same range, all other things being equal, for FY27, and then again for FY28.
Brian, the 3-year smoothing, was there consideration to using a 4-year period, and was 3 years just a consensus that was reached in the past?
Yeah, there was no real consensus on it. A 4-year was not discussed. It certainly could be And it could be a rolling, right? Because we're sitting here now based on what we think the next 3 or 4 years will be. And then next year we'll have a different view and we might reset it. Previously there was a smoothing approach that was looked at, and it happened to be a 3-year smoothing approach. It was a little bit different in that at that point in time, it was trying to solve for shorter term deficits, meaning that 27% rate action that we solved for would have been lower than 27% over 3 years for this, but much higher in years 2 and 3. In this case, we're actually kind of on the other side of the equation where we've got a little bit of a surplus running through the system right now because of the good experience in FY25 compared to budget at the time, as well as that bigger rate action actually carries forward now because it's already in place into future years. So it's a little bit of a different dynamic, but the 3 years is an arbitrary number.
That's fine. And let's say the upward cliff in fiscal 29 shown on this slide, by next year, that'll be part of the 3 years. So it'll be smoothed in. I worry about seeing that kind of cliff, but as long as it's going to be in there. And then, shoot, what was the second one? I guess that's, oh, I know. In the smoothing, you really solve for 2 things. One is you want to have 0 after reserves in the surplus at the end of year 3, but you also need to have a positive on that bottom line in all 3 years, correct?
Well, it's really a positive on the cash line, and we're now ultimately projecting to be relatively cash rich by the end of this year.
Okay, thank you so much.
Sure. And then again, the last.
Go
ahead.
Just a comment there. It's Brian Maxwell. I just want a point of clarity here. When we talk, there's like surplus in the system, like you say, currently as a result of that 27%. I would just want to point out to committee members that, we're working towards building up the minimum reserve. And I believe the target is around $76 million or so. And unfortunately, we're not there and we're working towards that. But like, if you were to actually put that in as your reserve, you wouldn't be seeing such a large like surplus, I would say. So Brian, if you could just talk a little bit about like what that minimum reserve represents and what we're working towards, because when people talk about surpluses, in my mind, it's not really a surplus because we're still not to where we really think the fund should be with regards to a reserve.
Sure. So the reserve, or more specifically the row that's in this chart that's labeled minimum reserve, is really there to protect the GHIP from volatility and experience worse than expected. And it was built in at starting at 2% for FY25, jumping up to 4% in FY26. Had we gone right to 4% for FY25, that would have meant that 27% rate action would have just been higher. But ultimately, we're looking to get to 4%. As again, call it a cushion for experience running worse than we anticipate, and therefore leaving the GHIP fund in a negative cash balance, which certainly we don't want to happen again. I mean, FY24 was kind of this triple bad effect where we had experience worse than we thought, trends running high, and then GLP-1 costs going much, much higher than original estimates. So it's a cushion there to protect the GHIP. And to the extent that actual dollars get above that cushion, let's use the word cushion again, then ultimately future rate actions would be lower because of it.
Bill Oberly?
Yeah, Bill Oberly. Brian, these projections exclude U of D. I had a couple sidebar discussions with other members over last week or so about the impact of U of D leaving the GHIP. And I have no understanding of the demographics of that group or their past impact on the fund. Did you have an opportunity when you carved out U of D to factor anything into the equation related to them leaving the fund?
Yeah, so we actually pulled some of their historical claims experience and pulled it out of the entire model. Generally each year, sometimes more than once per year, we have looked at all of the non-state employee participating groups and how their experience has run relative to the GHIP, noting that all of those groups not only pay the gross premium equivalent rates, they actually pay a 5% risk load as well for potential adverse experience against the GHIP. Now, a lot of those participating groups are small, but they do pay a 5% risk load. The University of Delaware has, I don't want to say exclusively without looking at all of the experience, but I think generally has always run better than the overall average GHIP experience, meaning you're not only losing that, call it better than average claims experience in the population, you're also losing the 5% risk load from that population as well. But these projections are based off of carving out actual University of Delaware data. Now, this is based on data through January. I think the last time we did it was based on data through December. But had U of D stayed in the population, this smooth 4.2% rate action would have been something like 3.8, I think. So it actually had a negative effect. It wasn't just a head count reduction, said another way, and everything else stayed the same on average. It actually had a negative impact on the projected rate actions. And U of D was big in terms of the participating groups. They were about 2/3 of the total pie of non-state groups. And then the last alternative, which is sort of a hybrid of the two, it looks at FY26 standalone, which was that 0%, and then does the smoothing starting for FY27, 28, and 29. And that would increase 27 through 29 to a fairly large 8.8% rate increase on average. But again, for FY26, it would be 0%.
What is the next step for this? Is this going to be on a future agenda as far as which of these approaches to take?
So, Faith, maybe keep me honest. I believe this is to be voted on during the March 21st meeting.
This is Faith Renz, that is correct.
So, Mr. Baumbach will probably have February data by then, which means we can factor in February data into the projection, and it may tweak up or down the 0% scenario is going to be 0% no matter what. It's just that the February experience might have an impact a little bit on the smoothing approaches, depending upon how February experience came in, if anything in sort of anomalous came in that wasn't anticipated. I do know we were expecting I think it's a $9.2 million EGWIP payment that I think was supposed to come in February. I don't know if it came in February or March, but it was actually $11 million. So that's actually a positive number, which would, modestly affect the projection a little bit to the positive. But either way, the intent is that you'll vote on which model, and then ultimately the rate action itself for FY26 under the model that's approved.
Does anybody have, I think Controller General Ruth Ann Miller has a question.
Yes, thank you, Director. So as somebody who just had to live through the budget cycle with a 27% rate increase, it was a tough go. And so I echo Representative Baumbach's comments about seeing that out year on the previous scenario of the 15% jump all of a sudden. And so certainly in all of those discussions that happened, I think the lesson learned was that it is much better for us to do some sort of increase each year, even if it's a modest one, so that we don't end up in a situation like that once again. But so my question would be, 4.2% versus like a 5% or a 5.5% doesn't seem like a huge jump. So could we look at some scenarios that maybe do something like that? And then maybe by that FY29 year, that percentage would drop.
Sure. Yeah, absolutely. I think historically one of the predecessors actually wanted to propose a model that there was a minimum 5% or 3% or
Yes.
something rate increase in any year, regardless of experience, just to protect yourself from never having to see that 27% again, kind of a thing.
Yes. And then, Brian, has anyone done any modeling on how much that actually, the 4.2% would cost the state as the employer share that would have to be added into the budget?
Yeah, that's here as well. So the state share, you're talking about aggregate dollars, or you're talking about on a rate basis?
I'm talking about the total appropriation amount that would have to be
Yeah.
added into the budget.
So
It's
That-
$27.5 million for FY26. And just to remind everybody, the GRB that's growing at 6.9% based on Governor Carney's recommendation, there was no consideration for a health premium increase. So we're at 0% right now as it stands, but that 4.2 would require $27.5 million general fund.
Perfect. Thank you so much.
Sure. So that's it on the rate scenarios. And then there were a couple of takeaways from the last meeting. One was a question relative to GHIP enrollment. I don't recall who the question came from, Stephen. I think it might have come from you. I'm not sure. So forgive me if it wasn't you. The expectations that, or the belief that the current enrollment was actually down in the GHIP versus up. Sorry if it wasn't you. When we recall that when we set budget, we have this assumption that GHIP enrollment will grow by 1% per year. That's still baked into the projections. We did a little bit of a sensitivity analysis on what impact it would have on rate actions and results should actual enrollment be higher or lower. It's fairly benign in terms of rate actions. This chart shows what enrollment was and what we projected it to be for FY25 budget setting purposes. So done last summer. You can see that actually over the 2 years from June of 23 through July of 24, enrollment had actually increased by 4%, but we still use that same 1% assumption going forward into the future. And then just in terms of how actual enrollment has played out so far this year, the column here in orange and brown to the right is what we set on a budget basis per month, and then the numbers relative to the other revenues. It may have been just a subset question relative to the other revenues subset of other revenues, but we've got sort of a description in here for the benefit of the committee relative to what makes up all of the different components of the other revenues. So we ultimately have, call it 4 major categories of revenue components offsetting the cost of the GHIP. One is prescription drug rebates, so manufacturer rebates on brand drugs utilized by GHIP membership, when we see those rebates on both the commercial side and the EGWP side alike. The participating group fees, that's the 5% load that we talked about a little bit earlier relative to the dropping out of the University of Delaware. So those groups get charged a 5% risk load plus an administrative expense for allowing them to participate in the GHIP. Then there is that other category, which is sort of a catch-all against everything else, miscellaneous things that might come up from time to time, performance guarantees, miscellaneous credits. Sometimes there are settlements from a litigation issue, things like that fall into that catch-all bucket, which is generally a projected to be on average a fairly low number each month, and then might blip up from time to time. And then all the different EGWIP revenue components, subsidization from the federal government into the EGWIP that I have more detail on future slides on that we can go to in a second. Stephen, you have a question?
Yeah, it's not really on revenue. So if you want to finish this, it's related, but it's not really on the revenue piece. So you may have some questions on revenue.
Okay. So again, you can see the two different rebate components, the commercial rebates and the EGWIP rebates make up a fairly sizable chunk of this other revenues category, in total projected to be about $180 million of the total $267 million forecast for FY25. You can see the other revenues component, generally a very low number, running, roughly $15,000-$20,000 a month. This $7.3 million was the payment back for the transfer into the fund to keep the fund in a cash positive balance at the FY24. Otherwise, big ticket items like that generally don't show up. We did have one other big item, a performance guarantee miss, so a payment back in July of roughly $1.6 million. And then the remaining categories are the four different categories for EGWIP revenues. EGWIP direct subsidy, reinsurance, year-end reconciliation, and then coverage gap discount. And that's basically the federal government subsidizing the cost as you running your own individually employer-sponsored Part D plan. And Stephen, you still raising your hand from that other question, or do you have something specific to this?
No, you can continue.
Okay. There were big changes starting, so the EGWIP runs on a calendar year basis. There were big changes to the EGWIP revenues starting 1/1/25 versus prior years due to the Inflation Reduction Act. They were actually good changes that were to the positive that we learned after budgets were set, which is why part of the reason why experience in FY25 is running better than expected. There at one point in time was a belief that the Inflation Reduction Act was going to cost employers more. Specific to your own plan design, there was certainly help, but there were big changes, ups and downs in the four different components between 25 forward versus prior to 1/1/25, which all netted out to more revenues coming into the EGWIP than originally were anticipated. The first component is what's called this direct subsidy, which is liken it almost to like a capitation or a base payment per member per month. It's calculated on a PMPM basis, and you can see in calendar 24 that amount was only $17 per member per month and jumped way up to $118 per member per month, predominantly due to the $2,000 out-of-pocket max going into effect under Medicare Part D. So a big jump in the direct subsidy payments. And when you go back and look at the other revenue flow month to month, you can see it was running roughly $500,000 a month, and starting in January jumped up to nearly $3.5 million per month. So a big increase in the direct subsidy. The federal reinsurance program went the other way and actually had two sort of changes. Just like the direct subsidy, the federal reinsurance program is calculated on a PMPM basis. So in calendar 24, the EGWIP was getting $91 per member per month in total. And for calendar 25, you can see there's a fairly big drop from $91 to $62, which is a $10 million-ish decrease in total in revenue on the federal reinsurance side. And you can see back on the direct subsidy, it's almost $36 million increase. But what they additionally did was they take this federal reinsurance calculation and they split it between a prospective payment and then a reconciliation on the back end. So not only did the PMPM go down, but the prospective share of that expected PMPM went down from roughly 75% of the $91 down to roughly 50% of the $62. And then around 12 to 15 months after the year is ended, this whole component is reconciled, and you get that third component, the year-end reconciliation payment, which usually happens either December or January. I think last year it happened in January. So in January, I'm sorry, the budget is that in January would have been 6.7. We actually got it in December, so we got 6.6. So that's in a good place. For FY25, you can see we had, back when we set budget, we had estimated that year-end reconciliation payment projected to be received in January of 26, because again, it's 12 to 15 months after the close of calendar 24 is the next one we'll get. We calculated it to be roughly $11.5 million in our forecast, and the latest estimate from CVS, I think, was 11.6 or $11.7 million. So it doesn't look like we have any big surprises coming in from the year-end reconciliation payment. Mr. Baumbach, you have a question?
Yeah, so maybe I'm not understanding this right, but what I'm seeing on the slide you have up is that for 24, what we expected was 7 million more than what we are getting and expect to get. But that difference is going to get paid to us anyway by
No. So what it?
No.
Yeah, sorry, no. What we're saying is the total federal reinsurance payment, the full $91 per member per month, will generate a grand total of $32.8 million that you will get, and it will be in 2 separate installments. Monthly prospective payments of about $2 million a month, totaling $25 million. And then at the end of the reconciliation period, 12 to 15 months after calendar 24 is done, assuming these numbers are right, you'll get another $7.6 million payment.
So it's just a timing thing. The dollars that we're expecting,
the total
we're
is
going to get,
32, right?
Spreading it across different years and stuff.
That's right.
Okay,
that's right.
Thank you.
But so the key point is that the federal reinsurance payments were expected to be $33 million for calendar 24, going down to $22 million and change for the plan year calendar 2025 with different timing.
Perfect. Thank you.
That's right. And then the last piece is the coverage gap discount program, which they're changing the name. It's now going to be called the Standard Coverage Phase Program. This also sees a modest decrease of, in total, roughly $31 million down to $29 million. And recall earlier I had said that our forecast had estimated that the Q4 24 coverage gap discount payment would be the $9.28 million. We just learned from CVS that it's likely to be closer to $11 million. So that's a positive, a gain relative to budget. Which will have a modest impact to the positive in the final rate setting scenarios that we present on the 21st for vote. But net of all of those things combined, you can see that the Inflation Reduction Act had a, call it plus 36, minus 10, minus 2, so almost a $24 million increase in revenues coming from the government into the EGWIP versus prior to the Inflation Reduction Act, prior to calendar 25. All right, Stephen, what's your question?
Thank you. Yeah, I might have missed this and apologize if I have. So in terms of the UD employees being now not included, all of these scenarios that you've gone over, are they out of the mix now?
They're out.
Okay,
They're out.
so the question I have is, I noticed there were no trend changes by taking them out, right? So, and I'm just saying, I don't know if this is the case, but I'll just illustrate what I'm trying to say. If their trend as an isolated group was 4, and the state employees and the others was 8, right? You would be concerned because your trend would you would have had a lowering of the trend because they were in. And also the vice versa. If their trend was higher, then and I'm just wondering if that has already been looked at, where we've maintained it at the same level, or we've made any adjustments on the trend based on them not being part of it now.
Yeah, I wouldn't, off the cuff, wouldn't change my trend assumption going forward. In other words, we're sitting here projecting how much we think average costs will go up by in the future, regardless of what those individual averages are. And if their average cost was lower, which is reflected in this base because we pulled their claims out, I would probably still set the trend assumption for them independently going forward at about the same.
Okay, I was just
same rate.
curious.
Yeah.
Because we look at Medicaid, for example, we look at it a little differently.
Yeah, the only thing that we generally look at a little differently here is just the Medicare population versus the non-Medicare population. But I wouldn't, based on their size and based on the reasons why we're setting, or the drivers of what we're setting in terms of trend assumptions, I wouldn't change the trend assumption unless they happen to be, maybe significantly lower utilizers of GLP-1 drugs, for example, because that was a specific sort of static thing that we were looking at because of the large impact it had on the trend assumption.
Now, in Medicaid, we have some
Cut the conversation
populations.
short. Time out. We're starting to run over time here with regards to what we allocated towards this discussion, so I apologize, but.
No, that's okay.
Have to move forward. So Bill Overly had a question. You're good?
Yeah.
Okay. So what I will say is I heard a lot of discussion as these different scenarios have been presented to us today. And obviously we're going to have to take a vote as to our path forward on March 21st. What I would like to ask my fellow committee members is to start thinking about ways the SCBC can reduce future health plan premiums. And in those cases, you should send them to Stephanie Hardis and at the SCBC@delaware.gov mailbox to add to the work plan discussions beginning in April. In upcoming discussions with the SCBC, Willis Towers Watson will kind of, as we've developed this work plan, we would start modeling what these recommendations would do with regards to potential plan savings. Because I know a lot of folks are hedging towards like this smoothing, which I'm an advocate for, but I want to remind everybody, I did hear from a committee member at the last meeting saying that kind of takes our foot off the gas as far as talking about change, and it doesn't, instead of talking about what we can do to bend the cost curve, we just talk about how much more money we have to put in the system. So I'm encouraging everybody to submit their ideas to that mailbox. And I look forward to working with everybody with regards to that. So I'd like to bring this particular topic to a close so we can move on to number 6, which is a pretty meaty agenda item. Does anybody have any quick comments with regards to that comment? Vice Chair, are you good with, do you have anything to add?
No, I think it's important that we continue to look for some of these solutions, and I'm excited to dig in.
Thank you so much. All right, agenda item number 6, which is the pharmacy benefit manager request for proposal scope of work. And I'm going to turn it over to
Sarah Tarnett
Sarah.
with Willis Towers Watson.
Yes, thank you, everyone. Yes, I'm here today to talk about the RFP for the pharmacy benefit manager. And if we can move forward on these slides. So currently you have a pharmacy benefit manager or PBM services provided by CVS. You have 2 different groups. There's what we call the commercial population. You're going to have your active state employees, including your school districts, charter schools, higher education. non-state groups that are allowed to participate. And then also your employer group waiver plan or EGWP population, which is your Medicare pensioners. We have some additional context on the slide for your reference, but I'm not going to go into detail on the information in this gray box. Moving to the next slide. So the current contract expires at the end of June 2026 for the commercial population and at the end of December 2026 for the EGWP population. Based on timing, in order to ensure that everything would be completed appropriately, we need to start the request for proposals now in order to allow for time to both conduct the procurement, which typically takes 9 to 10 months, as well as have contracting and implementation activities if needed. We looked for about 6 months ahead of that July 1, 2026 effective date for the commercial and January 1, 2027 effective date for the EGWP plans. So we want to talk today about the scope of services that will be incorporated into the next RFP, as well as an update on the market check and talk a little bit about the PBM marketplace as well that will be incorporated into the discussion on the RFP. Moving to the next slide. So yes, first a quick update on the CVS market check. WTW did complete a market check for the state as part of the contracting terms. We are able to benchmark the provisions against the market. If there is at least 1% or greater savings as compared to what we see in the market, what WTW benchmarks in the market, we provide that report to CVS. We did run that report for the term effective July 1, 2025 through June 2026 for commercial and for calendar year 2026 for the EGWP plan. WTW requested a proactive offer from CVS to be submitted. They submitted it back in January. They responded on January 17th that there was no opportunity for improvements, and therefore they did not provide an offer. WTW provided additional benchmarking information and asked for improvements the week of February 24th. And again, CVS came back and said that they are unable to make improvements because they are underwater on their current rebate guarantees. We are working with CVS to provide an option to further rebalance pricing between brand and generic specialty drugs so that we can ensure that pricing is more aligned with plan cost and what the actual price of the drug is in the market as compared to what may be happening today. So continuing to ensure that the pricing is fair and in line with the market. Speaking.
Can we take one quick question from Bill Overly?
Yes, thank you. You talk about rebalance pricing between brand and generic. Would that result in a change of the formulary?
No.
Okay, continue.
So giving a quick marketplace perspective, we wanted to make sure, give a quick overview of what it is that PBMs do. There's a lot of bullets here in this honeycomb picture, but they will distribute drugs for mail and specialty. They will work with network pharmacies in order to make sure that members have pharmacies that they can go to get drugs at a retail site. They adjudicate the claims and confirm, make sure that the pricing is in line with the contract that was negotiated with the plan sponsor, produce ID cards, handle member questions. They have utilization management programs, which make sure that drugs are being utilized as appropriate, and clinical programs to support the members that are taking the drugs, have call centers. I'm not going to, I know I've listed about half of them already, but just a general sense of the services that we need to ensure that any PBM that would be contracting with the state would be able to do. Obviously, because you have an EGWP plan, we also need to make sure that it can coordinate with Medicare Part D, coordinate with the medical and wellness programs, and provide data to your data warehouse. No questions. Moving to the next slide. So giving some updates on what other employers and plan sponsors are doing in the marketplace. We're seeing that more and more plan sponsors are looking to carve out the PBM services outside of the medical carrier. So today, again, by contracting with CVS, the state is already carved out. But in the past 6 years, we've seen an increase from, we've seen, we've seen an increase in carving out the pharmacy benefits with a reduction in the carve-in benefits. And as plan sponsors are looking ahead to what they might be doing in the future, as much as 3/4 maybe carving out in the next couple of years. In general, there is a view that the rebate program is advantageous to the company. And there's kind of about a 54% that agree that the PBM obtains the most advantageous pricing. But there is still 40% that would prefer to eliminate rebates in order to provide a lower list price at point of service. But only about 20% that would be willing to forego the lower rebates to have more focus oversight of drugs. So rebates is definitely an area that has a lot of attention, as I know it is important to the state as well.
Sure.
Bill Oberly?
Just one quick question on the limit. One quick question on the elimination or potential elimination of rebates. Would that provide for more transparency?
It depends. There are two ways to get more transparency. Either get more information on the rebates that you're getting today. Obviously, if there were no rebates and you were able to understand the price of the drug without the rebate, that would add to transparency. I see kind of two pathways to transparency, either not having the rebate or having the rebate, but actually knowing what it is. Which is one of the things that we'll get to later on, that we do want to have rebate reporting better rebate reporting as a requirement in the RFP. A couple of other perspectives that we wanted to share. So we continue to see more movement towards a transparent and pass-through contract structure for rebates. Again, the state did move to a more transparent structure in the last RFP. There is some interest in promoting drug discount cards to consumers to kind of get them be able to have more tools in their pocket. But I think what is most interesting here is these kind of last two items, allowing members to purchase drugs through a retail or cost plus outlet. Not a lot are doing it today, but there's certainly a decent amount of interest. So that could potentially, double in the next couple of years, and a lot of interest in acquisition cost pricing. But only about 6% of respondents were doing it today. So these will be things that we'll want to be talking about as we continue in the planning process.
Are either of those last two elements included in the draft RFP for PBMs that we'll be discussing today? I don't recall seeing those.
those are topics that so for today, we wanted to have a overview of the marketplace. But there are other topics such as cost plus and sorry, I'm trying to think went on my computer here for a second, sorry. And in the Mark Cuban cost plus drug plans, that is something we want to cover in more detail on the March 21st meeting.
Is the March 21st where we are voting upon the final RFP wording?
Yep, this is Stephanie, Statewide Benefits Office. No, currently the schedule to approve the PBM RFP would be a vote in May.
Oh,
For the
perfect. Thank
full
you.
RFP. Yes.
Thank you. There are no further questions. I can move to a little bit more on the marketplace perspective. So we did want to give a little bit more information on cost plus models and how it compares to what you have in place today. So today, the state has what we call an AWP, that's based on your average wholesale price with pass-through offer. And again, there's a lot of interest on what you call a cost plus option. When we're talking about adjudication, we're talking about how that claim is priced at the point of sale. So it really impacts both what the member pays at point of sale, as well as what the plan ultimately pays when they pay their portion of the claim. In general, when we see the difference between these two models, it is not intended to generate savings or a cost, but is really focused on rebalancing costs for drugs to align with the actual acquisition cost of the drug. That does mean that there could be both winners and losers from a member perspective. Under the average wholesale price pricing basis, the cost of the drug is based on that price before any discounts in the Medispan database, and discounts are applied off of that. We find that the PBMs, like kind of where their focus is and where they're making money is on administrative fees, but there's spread on any mail and specialty pharmacies that they own, but they are passing through what the pharmacies themselves are paying. So a retail pharmacy is making money on potentially dispensing fees, although these are often very, very small. But they could be making money on variable margin on drugs compared to what the pharmacy is able to acquire the drug for. But the PBM is passing through exactly what they are charging the pharmacy, is what the plan is paying. Under an acquisition cost plus model, the cost of the drug would be based on a more acquisition cost pricing, meaning the price it cost for the pharmacy to acquire the drug. Usually it's based on a benchmark such as NADAC, which is your national average drug acquisition cost, or a estimated acquisition costs. Sometimes they'll use several of those benchmarks to make sure that that the plan is getting the best price of several benchmarks. In this case, the PBMs would be making money on admin fees and any disclosed margin and dispensing fees on PBM owned mail and specialty pharmacies, but it would have more transparency there. And we'd also see higher dispensing fees paid to the retail pharmacies, and whether or not they make margin on the drugs, we'd expect it to be much smaller since the drug is aligned with the average acquisition price, but we don't know actually whether the pharmacy was able to acquire the drug for more or less than the average.
Would you be able to generalize and project the likely impact on the cost of the GLP drugs in a shift to an acquisition cost approach?
So we can look for drugs that have a NADAC price. We can compare what you're paying today compared to what would be paid on NADAC if that is the benchmark, for example. And all of this is before rebates. Rebates would continue to be passed through 100% as they are today under both models.
Bill Overly?
I'm trying, I've been down this rabbit hole for a week now, looking at the PBM proposal and trying to glean as much information as I can. In our current situation with CVS, are the administrative costs separated out? Do we know what they are?
So there are various administrative fees that are paid out. Most of them are the core admin fee, and there also may be clinical program fees. They should be we should be able to have those separated out. Dispensing fees are not administrative fees. I think that I'll point out. Dispensing fees is what's paid to the pharmacy. But sometimes there is confusion. Those ones are built into the cost of the claim.
And all discounts and rebates are passed through back to the state
Correct.
in the current model.
Correct.
So, Joe,
Aaron Peterson?
yeah, so you'll provide those fees, the administrative fees? Or are they very similar in these documents?
They're not in this current document. As part of the RFP, we would be comparing the admin fees as projected under the current plan compared to the proposals that we received from the PBMs.
And can you tell us what those administrative fees are for this year or current year?
Yeah, I think, Brian, we can work together to collect the current information.
Okay, so all other rebates and such pass 100% back to the state?
Yes.
Is there spread pricing involved?
There is no spread pricing with the retail pharmacies. It is 100% pass through. That was a change that we made in the last RFP.
Okay, thank you. And so you'll get those administrative fees to us and
Yes. So as we talk about the proposed scope of services that we're working on, we want to make sure that all of the typical and specific PBM functions on the honeycomb slide, as I'll call it, are included. We want to ensure that there is transparency in contracting terms for both the traditional or non-specialty drugs as well as the specialty drugs. We want to make sure that there is competitive financial terms. So your drug prices, your fees, credits, performance guarantees, discounts, etc., are competitive with the market. We want to make sure that we have excellent account management services to the state for both implementation as well as ongoing account management staff. Reporting needs to be meaningful and timely. Including detailed reporting of rebate payments by drug. So that's, to the earlier rebate drug level transparency that we were talking about. And also reporting to other state agencies at the request of SEBC and SBO. That will include the annual completion of the Delaware Department of Insurance Office of Value-Based Healthcare Delivery and PBM collection template. And certainly responsiveness to changes in the program and requests of the SBC and SBO. Yes, question.
Yeah, just curious, is network adequacy no longer an issue where it's not highlighted? I know there were some concerns on the last process about making sure the network of pharmacies, independent, chain, et cetera, was adequate. I'm just wondering if that seems to be solved in the current state.
So we will be looking at the pharmacies that your members are going to today and asking any PBM to note any pharmacies that would be moving to out of network. So that will be part of the process as well. But I'm not aware of any current concerns about network adequacy.
I thought there was a point, maybe the staff, there was some pharmacists that were concerned independent pharmacists, not so much the chains. But it could be resolved and, I'm fine with that. That's always an issue that comes up.
Mr. Bombay?
Yes, if there's a change in the PBM that the state selects, does that change any members' qualification for medications that have already gone through a pre-qualification? Does the PBM do any of the pre-qualification, or is that all at the healthcare contractor near the Highmark, whatever? Or does the PBM have a role, and if you change PBMs, does the member have to go through those hoops again?
Brian, do you want to take this one? Oh, Brian, I think you're somehow muted. I do know that as part of the implementation process, I'll see if Brian can join, but I'll take a shot at this. You can yell at me or wave at me if I'm doing it wrong. As part of the implementation process, the PBM, so first of all, your first question, the PBM does handle the prior authorization of the medication. As part of the implementation of it, process, some of those prior authorizations can be sent through to the new PBM to reduce the amount of prior authorizations that will be needed. There can be exceptions on specific classes, controlled drugs, for example, but that would all be handled in the implementation process. I see Brian nodding. I think he may be forced on mute. Sorry. Brian, I think you are now available. If you have anything to add to that, you should be able to unmute now. Oh, okay. Sorry, I guess it's not working. Any other questions? Sorry, Brian.
Sarah, we're gonna have another chance to discuss this in more detail. Obviously, we wanted to have an initial discussion about it because it is on our list of things to do. And as previously mentioned, we will have to vote on this RFP in May. But we are running short of time, and we do have another RFP that we actually have to discuss. So I'd like to move on to the next agenda item if possible. Thank you.
Okay, no problem. Thank you.
So I believe we're on item number 7, life insurance benefit request for proposal. And it is Jacqueline from Willis Towers Watson.
Yes, thank you, Director Maxwell. Good afternoon, everyone. I'm Jacqueline Iglesias with Willis Towers Watson, and I'm joined today by my colleague Tyler Vanagas, who's one of our life insurance subject matter experts from WTW's Life Absence, Disability and Leave Management Practice, and we'll both be presenting on this topic this afternoon. So just to provide a brief bit of context, so again, this is on the Group Universal Life insurance policy. The state's contract with Securian for this benefit will expire on June 30th of 2026. Throughout the summer last year, the SEBC and Health Policy and Planning Subcommittee had several discussions about the scope of services for this upcoming life insurance RFP. And there was quite a bit of feedback that was collected from committee and subcommittee members and has been incorporated into the final scope of services that the prior committee voted on and approved at the September 2024 meeting. So while the intent of today's discussion is really to talk about the content of the full RFP, we do intend to provide just a brief recap of what the final scope of services looked like, as well as some commentary around how some of the earlier concerns that we heard from SEBC and subcommittee members were addressed in this final scope, along with, again, an outline of the RFP questionnaire and just some key takeaways in terms of next steps. One of those key takeaways is soliciting some additional feedback from this committee on the final version of, or the full version, I should say, of the life insurance RFP, which the committee will vote on at our next meeting on March 21st. So to touch briefly on the scope of services within the full RFP. So in the conversations that were had with the SCBC and subcommittees, we did hear and discuss a number of concerns about the differences in the value of the benefit being provided between a group universal life insurance product, which is reflective of what's currently offered to state employees today, and a group term life insurance product, which is not offered to state employees, but those who do participate in the life insurance plan do have the option of covering any eligible spouses or children with a group term life product. So we had several discussions about group term life for employees. Some of the feedback that we heard from committee and subcommittee members were concerns around the group universal life, what's in place today, offering a greater benefit to employees, but at a higher cost. And then there were also some questions brought up around what would employees value more, which type of life insurance product. So to address those concerns brought up by the committee and subcommittee members last year, we have developed the RFP to allow life insurance carriers to submit proposals on up to 4 different plan options, including option 1, which is listed here in the chart, which essentially matches the current life insurance benefits with group universal life for employees that exists and is in place today. In addition, the Statewide Benefits Office is preparing to release a survey to state employees, both those who are currently enrolled in the life insurance benefit today and benefits eligible employees who aren't enrolled in the current plan, really to understand what their preferences are with respect to these 2 different types of life insurance products. The intent is to have this survey data available to allow the proposal review committee that is going to be meeting to discuss the proposals that will be obtained through this RFP. The intent is to allow the proposal review committee the opportunity to review these survey results as well alongside of the RFP responses. I should also note that SCBC members were solicited for feedback and provided such feedback on the draft of the survey in January, with the survey then targeted to still be released this month. So I'd mentioned there are the 4 different options. Options 1 and 2 are both structured around a group universal life product for employees. The only real difference being that there are some benefit enhancements or improvements to the existing benefit that are incorporated into option number 2. And then similarly, options 3 and 4 include group universal life as the insurance product for employees. Option 3, which again resembles the current life insurance plan with the exception of the type of insurance product offered to employees. And option 4 is the same sort of enhancements that are captured in option 2, but again, having a group term life insurance product offered to employees instead of group universal life, which is in place today. One of the other items that I'll just briefly touch on before I pause is we had some conversation with the subcommittee and SCBC about back last summer, that is, about the potential challenges with offering employees the choice of group universal life and group term life at the same time. And the discussion at the time was around it would be too difficult for life insurance carriers to actively price out both options, meaning both group universal life and group term life, if they were both offered as a choice alongside of each other. And that would essentially defeat the point of trying to get the most competitive premiums for the benefits offered. Again, recognizing that this is a benefit that employees pay the entire cost for. There's no state funding for life insurance. So, as I said, life insurance carriers in this process can submit proposals for up to these 4 options, and then it will be up to the proposal review committee that will be meeting to review these proposals to formulate a recommendation to this committee around which of the 4 options would be best suited to meet the future needs of state employees. Are there any questions or comments about the scope of services?
Bill Oberly. Yeah, Jacqueline, going back several months, were we ever able to resolve the portability question around Group Universal Life if we were to convert to a term situation?
Yes, Bill, I believe so. And let me just briefly restate that just to make sure we're on the same page about what that particular item was. I think the question that was asked several months back was around, in the event of moving from Group Universal to Group Term Life, would there be individuals who are in the current Group Universal Life plan that wanted to keep that coverage still be able to port or take that coverage with them if the state were to terminate the contract for Group Universal Life? Is that?
Yes.
Okay. Yes, that is the case. So the portability provision would exist for those Group Universal Life plan participants that wanted to stay with the Group Universal Life. It would likely come at a higher premium cost because the portability feature does have more expensive premiums than the premiums that active state employees pay. So that would be a consideration, but there is potentially an option for those participants who want to keep that coverage.
Thank you.
So in the interest of time, just moving briefly to the RFP questionnaire topics, I'm going to turn it over to Tyler to take us through this outline in a moment.
Great, thanks, Jacqueline. So basically what we want to do on this slide here is kind of outline what the RFP questionnaire would entail, and just to make sure we can get an understanding of what kind of questions we'd be asking these vendors that are quoting on the life insurance RFP for both the GUL and the term life. So the types of questions are, for instance, is the organization overview, where we're going to figure out how long these vendors have been in business for, what types of other clients they have, and how many types of clients they have that may be similar to the state of Delaware, to get an understanding of their capabilities to handle, a larger account such as the state of Delaware. Account management team and processes, that's for understanding who the account manager and who the account contact would be if they were to be awarded the business, and kind of what the team structure would be like. For implementation process and capabilities at a high level would be understanding how long of an implementation window would be needed and to make sure that they can adhere to the state of Delaware's implementation time constraints. For life insurance and AD&D capabilities and coverage, that's trying to make sure that they can match the current life insurance and AD&D provisions that are in place on the GUL policy today for both GUL and term life, and to see if there was any specific deviations that they might have from the current plan design, and trying to make sure that they can match it as close as possible. For administration and claims processing, understanding how the claims team works, how the intake team works, how many hours a day they're available, do they have 24/7, 365 intake, trying to understand that. Can they submit online through a portal? For reporting capabilities is understanding what kind of reporting is available to the state of Delaware as far as claim approval status, how frequently that's updated. Is it real time? Does it batch overnight? And other types of reporting as far as, if the claim has been paid out or not. For evidence of insurability, which is also known as proof of good health, we'd ask types of questions to understand what their process is for evidence of insurability. How long is the questionnaire, and what types of processes do they do to screen someone to ensure that they're in good health in order to insure them if they are a late entrant. For portability provisions, in addition to the portability question we just addressed, if someone were to, for instance, leave their job, would they be able to convert that into an individual policy and be able to keep a certain amount of their insurance if they were to leave their job at the state of Delaware? We would ask questions around that and how long they could keep that individual policy up to what age. For premium waiver provisions for disabled participants, understanding what their premium waiver provisions are, as far as if you're disabled after a certain amount of months, are you able to, after what time do you have to stop paying premiums to keep your life insurance, and other questions surrounding that. Until what age? Is it to the Social Security normal retirement age? Is it to age 65? And understanding if they can match the current provisions that are in place today. For life record keeping and administrative services, we'd be interested in knowing what kind of services they do offer, as far as how can they help on the administrative end. Can they do like beneficiary designation services? Can they as far as do they offer any like therapy services or anything for someone going through, for like such as a spouse of someone that has had to file a life claim, and what other types of record keeping abilities they may have. For the financial proposal component, essentially we are going to look at the financials of the 4 different options so that can be presented to see what the delta is from each of those provisions. And so not only understanding if, you know, term life or GUL would be a better fit, but where it would impact from a financial perspective. For these last 2 bullets here, the technical standards, security requirements, as well as miscellaneous provisions, these are to make sure that the vendors adhere to the state of Delaware's current standards and provisions that they have in place today, and make sure that, you know, if there was the possibility of a vendor change, to make sure that they would be adhering to the current provisions in place going forward. I know I just said a lot there. Is there any particular questions on any of these bullets or the questionnaire in general? All right, well, if no further questions, I'll pass it back to Jacqueline.
Thanks, Tyler. So just to wrap us up, a couple of key next steps. So for the committee members, please note that the Statewide Benefits Office sent the full RFP document out to the committee as a Word document with the track changes function enabled, and committee members have been asked to review the RFP, incorporate any edits or comments you may have with that tracked changes function left on, and please return any comments or changes requested to Stephanie Hardus at the Statewide Benefits Office by the end of the day next Monday, March 10th. One other point that you should note: the SBO uses the Government Support Services standard template for RFPs, meaning there may be certain technical changes and legal edits that might not be able to be incorporated as a result of using that standard GSS RFP template. And if the committee would consider a targeted review, we think that the kind of key sections for you to focus in on would be Section 3 around the minimum requirements and general evaluation requirements, Section 4, subsection C, the RFP evaluation process, and then finally in the appendix, attachment 20, which is the RFP questionnaire. And I'm fairly confident, and Stephanie, please keep me honest, I believe that email that did go out to committee members did have those sections noted specifically. So again, realizing that's a mouthful, and you know, you may want to refer to that email for that specific information. Again, the SBO and WTW teams will take any feedback received from the committee and incorporate that into a final version of the life insurance RFP, which this committee will consider for a vote at our next meeting in 2 weeks. And then finally, as I said, the SBO is still planning a launch of that employee survey later this month.
Can you put that email address in the chat, or is it already in was it already in the email invite?
This is Stephanie Hardis, Statewide Benefits Office. This email was sent to committee members on February 28th, last Friday. We would be happy to recirculate today after this meeting.
Okay, I should be able to find it. Thank you.
Bill Oberly?
Yeah, one question around the questionnaire that would be submitted to employees. We won't know what the rates would be for group universal life for term until we receive the bids. I mean, term insurance is going to be cheaper in terms of overall cost. I don't know how you reflect that in the communication to employees.
I can jump in. This is Stephanie Harness,
Yeah.
Statewide Benefits Office. Mr. Overly, to address your concern, we are also, with the survey that we are sending to employees, they are also getting a training to provide that background knowledge and education on the difference between term life and group universal life. So to address your concern, you are correct. We wouldn't know the exact bids for the life insurance product for either group universal life or term. But what you had mentioned, the term life tends to be cheaper. That is correct. That is in that education material.
Okay.
However, universal life on the other side has the other benefits such as the cash value account that term life does not have. So yes, we are providing that education
Okay.
prior to soliciting the feedback.
Thank you.
Thank you, everybody. With regards to number 7, I think we're moving on to item number 8, SCBC planning, future agenda items. This agenda item's been put on the agenda as kind of like a standing agenda item. Well, what I do want to expand on is just, we put this on the agenda, but I would like to update committee members on a revised approach for requesting agenda topics for future SCBC meetings. Committee members should send agenda item requests to Stephanie Hardis at scbc@delaware.gov mailbox, and should not send agenda item requests or other discussion items to the full committee. If you have any questions on that process, please reach out to Stephanie directly. This is to avoid us doing business outside the committee. So to comply with that, we've come up with this process. Does anybody have any questions with regards to that recommendation? Great.
So, Chair, no questions, but I just want to reiterate your point. I think I've had a couple of emails sent to me that had a couple of committee members on that email thread, and I did not respond to many of you who may have emailed me. So I just want you to know that that's why, just so that we're not doing committee business outside of the committee.
Thank you for that. So if we could put up the slide, I just want to remind everybody of really the critical items, because we really haven't gotten to the work plan, right, in that discussion. Michelle, I see you want to say something. I'm sorry.
Sorry, Director, I could have just interjected, but I would just expand upon that and recommend that to the extent it's not already clear, comments regarding the RFP, I would also recommend be sent directly to the email and not copy all members.
Thank you for that. So the slide, this is a slide that we had at our last meeting, and you can see that based on the items that we've had on our agenda, they're very pertinent to decisions that we have to make in a very, very short, critical time frame. So we haven't gotten to the work plan, but the work plan is something that is going to be up for discussion coming in the April timeframe. So I want everybody to be thinking about those types of things. Obviously, we have a lot of items that we need to vote on at the SCBC March 21st meeting. And you can see a lot of those as far as the health plan rates, vote on the benefit design changes that Leanne reviewed with us today. And then we're going to review that scope again of the PBM and the vision RFPs. And then we actually have to vote on the life insurance RFP. So there's a lot of voting that has to take place in our next meeting. But I also want to, provide the opportunity for if anybody wanted to discuss any particular agenda item. I'm not sure if we would be able to get it at the next meeting, but we can start thinking about those items to kind of start plugging and playing with them as far as mapping them out.
Right.
Bill?
Yeah, I just wanted to put on the table, and like you, Mr. Chairman, you've got a lot of irons in the fire in terms of budget. things are happening at the federal level that don't look real great in terms of Title I monies and Medicaid issues. So I kind of approached this, and how can we perhaps take an approach that would dramatically alter what we're currently paying for services through our PBM, and later on open up a broader discussion around our TPA approach. But that being said, I'm not sure in the current structure of the RFP whether it allows for consideration of things like a reverse auction, which has proven very successful in other states, New Jersey, Connecticut, a couple others, where they've driven down their drug costs by billions of dollars by using a reverse auction approach. And I just want to, I guess I want some comfort level that at least at next month's meeting, we can begin to talk about, I call it a solution for a current problem in that vein. So
knowing that it wouldn't be effective, like the PBM, we're all gonna be on an extension, but the RFP that we're going out for is for services that begin July 1 of 2026 through June 30th, 2027 or beyond, right?
I just want to make sure that the way the RFP is constructed would not preclude that as an option.
Yeah, I think specifically to the reverse auction, there is some restrictions under current procurement laws, right, that we would have to amend.
State runs, that is correct.
Yeah, I believe it would require enabling legislation.
Right.
Which would obviously result in a dialogue with members of the General Assembly. I know there is some interest. I haven't had a discussion since I've been appointed to the SCBC, but last year I had various discussions with members of the General Assembly who I think would like to see a change in approach. I think that might be acceptable.
Yep. So we will, I think the action item is for us to explore how we can get that type of dynamic in this RFP that we're getting ready to go out for proposal. So that is on our to-do list, and obviously GSS falls under the Office of Management and Budget. So I would be consulting my folks with regards to what would have to happen. And I believe in the past, there's been times where Epilogue has been put into an act to enable some of that, but obviously want to do everything in a transparent manner. So we'll take that under advisement.
Thank you.
And Mr. Chairman, also, I don't know if people will be prepared to talk about this at the next meeting, but I noticed something that might be restrictive in the RFP, and that is that bidders must have 10 years experience in this and 10 years experience in that. Are those numbers based on something, or are they just arbitrary? Because that could very much limit our pool of bidders.
So who from Willis Towers Watson could possibly address the years of experience with regards to the PBM requirements?
What specifically about the years of experience was the concern?
The number of years.
What is based on, what those numbers are based on?
So you're asking if the for what years of experience, when we ask the question, how long have you been a PBM and what years of experience, it should be for the years that they have been active as a PBM.
Yeah, that wasn't my question. The RFP says that only people with, or bidders must have 10 years experience in EGWP, 10 years experience in something else, commercial, right? And I was just wondering where those 10-year requirements come from, because that would pretty much only apply to the three big PBMs.
There are a lot of PBMs that do have the 10 years or more, but we can certainly, it is planned to work through the requirements. And that was one of the items we actually skipped earlier because we ran out of time, but we want to make sure that we will be working through the requirements and making sure that the minimum requirements are adequate moving forward.
I was just curious where the 10 years came from, I guess. There's some.
Yeah, It's generally to make sure that the PBM has had enough time to establish, make sure that we have had time to get feedback on the experience with what they have done in the marketplace.
So it's not based on any, like, any kind of
We're not
research?
specifically
arbitrary
trying
number
to exclude any specific thing. No, it's based on the amount of time that we think would be needed to have adequate experience, to have a good sense of if they can really administer the benefit. And make sure that they wouldn't be going under anytime soon.
We could talk more about that.
Yes.
That's fine.
Yep.
Absolutely.
So I think that leads us to agenda item number 9, public comment. So if individuals would like to make a public comment, please indicate so now.
This is Amber Cahill. We have nobody registered for public comment. And nobody in the room wants to make public comment, correct? Okay. Give me 1 second, please. Okay, Stephen LePage, go ahead.
Can you hear me?
Yes.
Great, thank you. I was listening pretty intently to the when they were talking about the pharmacy benefit plan and that the state was getting all of the rebates passed through and things like that. And it seemed to me that when that discussion was taking place, it seemed like, well, why would we ever want to move? We're getting everything that we need. But it doesn't connect with me. Because when I do research on the drugs, there has to be something else that's causing the high price. Because, you know, like for instance, I've used Cost Drugs Plus for a number of examples. And if I, like pantoprazole, in the Silver Script statement that I get, it says that I paid $20 and the plan paid $38, making the drug $58.27. But when I compare that, the same drug, to Cost Plus Drugs, the manufacturing's $3.56, 53-cent markup, $5 for pharmacy labor, $5 for shipping, making that drug $14.09. Why? Why are we paying considerably more? And then, I mean, other things that I noted where, you know, I'm paying a $20 for the drug and the plan paid $16 for the drug. You know, I'm paying more than the plan pays. So something is just not clicking with me when when an explanation is given that kind of makes it appear that the PBM that we've got seems to be okay. So I'm just not fine with that, and that needs to be looked into. There's got to be something that's making those costs higher, and we've got to dig in and find out what it is. Thank you.
Okay. All right, Mary, go ahead.
She's muted herself.
Mary Graham, you should be able to unmute your microphone.
Mary. Mary doesn't seem to be able to unmute herself. All right.
She is unmuted on our end. Mary, can you try to unmute, please, so we can take your public comment?
Can she just submit her comments in writing?
Mary, there appears to be technical difficulties with you being able to unmute yourself. If you could please submit your public comments to the mailbox, is that correct?
Yes, it's sebc@delaware.gov. You can please submit your written public comments. They will be distributed to the committee.
Is there anybody else that would like to make public comment?
Thank you for that. So we're at agenda item number 10, other business, and I do have something for other business. I just want to put out there for committee members, if you have questions on meeting materials or information provided by SEBC consultants, members should contact Stephanie Hardis with questions and should not contact consultants directly. Statewide Benefits Office is the holder of the contract with regards to the support that's provided by our consultants. So they should be the ones that are directing the work of the consultant. Obviously, you should submit any questions to them directly. So, thank you. So that takes us to the end. Can I have I'll entertain a motion for adjournment.
So moved.
Can I get a second?
Second.
All in favor? Aye.
Aye. Aye.
Thank you, everybody. Enjoy your weekend.
Thanks so much. Take care.